Hello, my name is Anna Vaidya. I am currently pursuing my psychiatric mental health nurse practitioner degree at the University of St. Augustine for Health Sciences. This is my evidence-based solution to show how to utilize and implement the collaborative care model into a pediatric primary care clinic. My interest in this topic stems from my passion for mental health care and my role as a mother, where every day I try to teach my children the importance of how to deal with complex feelings in a productive way and within a safe space. 15 to 20% of children are diagnosed with depression by age 18, and of that, only 40% receive care. Additionally, there's an increasing shortage of mental health providers hindering access to care. COVID-19 has also worsened health outcomes for children as well, and they're now experiencing higher levels of depression and anxiety paired with lower levels of emotional and psychological well-being. To meet the growing demand, the American Academy of Pediatrics issued guidelines for adolescent depression in primary care. All patients aged 12 or older get yearly depression screenings during their well visits, and if they're screened positive, the provider reviews to see if therapy or medication is indicated. The purpose of this presentation is to use my PICO guided question to examine if pediatric patients ages 6 through 18 diagnosed with or screened positive for depression does integrating mental health care into primary care through a collaborative care model compared to outside referrals to mental health specialists increase treatment adherence and decrease disease severity over 12 months. Long-term complications of untreated depression include substance abuse, more severe symptoms, adult depression, teen pregnancy, higher high school dropout rates, and suicide. Other groups facing significant health disparities include ethnic minorities, rural residents, and people living in poverty. Racial and ethnic minorities often encounter more barriers to mental health care stemming from financial burdens, stigma, insurance issues, and socioeconomic status, all of which can negatively impact quality of life. Patients in rural populations are less likely to receive treatment and face higher rates of disease severity, stigma, and provider shortages. Insurance limitations also pose challenges for patients. For example, patients with public insurance are more likely to seek consultations with mental health specialists, but many private providers only accept commercial. Long wait times are another barrier that can lead to worsened outcomes. Additionally, patients often encounter underrepresentation in their mental health care providers as well, which can act as a language and cultural obstacle. A third of the population is Black or Hispanic, but they only account for 10% of the nation's psychiatrists. Additionally, there's a noticeable shortage of behavioral health care workers, including psychologists, physician's assistants, psychiatrists, and other mental counselors, which continues to grow. Approximately 1/3 of the U.S. population lives in a mental health professional shortage area, with rural regions facing increasing deficit compared to urban areas. For this presentation, I will refer to collaborative care as a general term referring to any method of integrated care. The collaborative care model is a specific model that I will go into more detail on the next slide. With increasing mental health needs combined with provider shortages, integrated primary care offers several solutions to address this challenge. Different models exist, but key themes include team collaboration, proximity, and a shared vision that ensures their success. Patients benefit from this as well. The YPIC trial showed decreased depression scores. The ROAD study noted similar findings at 12 months and had higher levels of evidence-based practice interventions of 86% versus 32% respectively. Systematic reviews show collaborative care improves depression in adolescent and young adults. Providers benefit as well through increased confidence in leadership support, fostering greater engagement with providers and staff. Although there are different variations in how these models are implemented, they've been proven more effective in managing depression in the primary care setting than standard care. The collaborative care model uses a behavioral health care manager who coordinates care between the patient and other clinicians. The team also includes a psychiatric consultant and the primary care provider. While in the primary care setting, the primary care providers work to start medication if indicated, offer psychotherapy or other evidence-based interventions, and the consultant makes treatments adjustments if necessary. The collaborative care model has the potential to deliver team-based care to better manage pediatric patients with depression by providing timely, evidence-based interventions, which can help improve their symptoms. So for my PICO question, in pediatric patients ages 6 through 18 diagnosed with or screened positive for depression, does integrating mental health care into primary care through a collaborative care model compared to outside referrals to mental health specialists increase treatment adherence and decrease disease severity over 12 months? The population is pediatric patients ages 6 through 18 who screen positive for or are diagnosed with depression. The intervention is the CoCM model that consists of a BHCM, a psychiatric consultant, and a primary care physician. All pediatric patients ages 6 through 18 are screened using the PHQ-9, and if it's positive, they're referred to the BHCM for immediate intervention. The control for this project uses the definition of enhanced usual care outlined by Richardson et al. Families and patients are provided with information about the patient's test results, and guidance on initiating care with an outside mental health provider is given. The primary outcome, is the reduction in PHQ-9 scores after 12 months. The secondary outcome is treatment adherence, which will be assessed at the end of the 12-month period and involve reviewing the attendance records, specifically the number of treatment sessions attended compared to recommended ones. Another outcome being measured is staff engagement, which will be assessed at 3-month intervals using self-report data and qualitative interviews. CINAHL, APA Psych articles, and PubMed were searched using the keywords, mesh terms, alternate spellings, and Boolean terms listed below. This yielded 57 articles. Next, Google Scholar yielded 2 additional studies, and a further review of bibliographies led to 4 additional studies, bringing the total to 63 studies to review. Finally, some of the studies that met, in part, some exclusion criteria were reviewed further to determine if they were significant to the project. A systematic review by Yonek included adolescents and young adults aged 12 through 21, but it was considered relevant to include. The YPIC trial had participants aged 13 through 21, and additionally, a systematic review by Hellstern et al. Was used as a background on collaborative care models in the adult setting, providing a valid comparison since adult models are more widely researched than pediatric ones. They also noted that most of their studies were conducted in the US, however, 8 out of the 34 involved other countries. But this was the most recent systematic review, so it remained relevant. Finally, the original randomized control trial by Astronaut was considered as a key inclusion because it was the first to focus on pediatric patients. After identifying the most pertinent studies for the project, a total of 10 quantitative studies were included in this research. Synthesizing the literature provided insight into 4 key themes: improved clinical outcomes, importance of evidence-based interventions, improved access to care, and patient, family, and provider satisfaction. All 10 quantitative studies had improved clinical outcomes measured by their respective screening tools. Black youth had the largest reduction in depression symptoms compared to other demographics, highlighting the potential to reach minorities and other underserved populations effectively. Symptom reduction was observed in patients with depression and anxiety, as shown by decreased PHQ-9 and GAD-7 scores, indicating potential future uses of CoCM models for other mental conditions besides depression. The next theme was the importance of evidence-based interventions. 7 studies supported the use of integrated CBT, psychotherapy, or both. Astronaut found their patient population preferred psychotherapy over a combined approach or medication alone. And it also was conducted over multiple sessions, helping ensure patient adherence to treatment and follow-up care. Burkhart found that providers tend to have greater confidence in treating mental health disorders through an integrated approach. Additionally, training in CBT or similar models enables the provider to use evidence-based interventions for short-term behavioral issues. Astronaut emphasized that integrated behavioral health care without evidence-based interventions may result in significantly worse patient outcomes, highlighting the importance of this component in collaborative care. The next theme was improved access to care. Yonek found that improved treatment adherence results from collaborative care, suggesting that integrated approaches help patients complete their treatments. Kinney observed that factors linked to treatment adherence include lower perceived stigma, prior mental health treatment, and higher levels of need. Rapp noted that as adolescents approach adulthood, they become more reluctant to seek treatment, highlighting the importance of integrated health care to catch missed opportunities as children grow out of parental involvement. Chang noted wait time improvements from months to immediately. Government policy mandates can enhance integration efforts and increase access to care by volume. This was evidenced by a depression screening rating of 87.03% among adolescents due to state-mandated mental health screenings in Minnesota. Many collaborative care models have chosen to accept Medicaid, thereby expanding access to underserved populations. The next theme was patient, family, and provider satisfaction. Yonek noted increased patient and family satisfaction within these models. Chang described the challenges parents face when making multiple appointments for primary and mental health care and noted that family satisfaction was influenced as a result. Providers benefit from these models as well. Pediatric primary care physicians report increased confidence in treating these disorders within these models, and patients report higher satisfaction within these programs. Astronaut observed that increased competence in providers improves treatment capacity and suggests that mental health care could become a routine aspect of general practice. All of these findings suggest families and patients experience a higher level of satisfaction with the quality of care they receive. This project will take place in a pediatric primary care clinic in Orlando, Florida. Staff will receive 6 weeks of training in the identification of roles, tools, and protocols. This will include sensitivity training as well to assist in treating those in ethnic and cultural minorities and illustrate how to provide culturally competent care. All patients ages 6 through 18 are going to be routinely screened for depression using PHQ-9 scores. If a patient scores 10 or higher, they're introduced to the behavioral health care manager for evaluation. The BHCM performs initial and follow-up assessments and meets with the psychiatric consultants weekly. Additionally, they oversee and track the response to treatment. The consultant recommends treatments and adjusts the plan according to patient's needs, and the PCP oversees the patient's care and prescribes the medication while meeting with the BHCM and consultant to make changes if needed. Using Cotter's process for leading change, I'll begin by educating the staff at the primary care clinic with my findings. I'll gather together an innovative team with a behavioral healthcare manager, PCPs, mental health providers, nurses, medical assistants, informatics, and leadership, and use that team to create the CoCM in our clinic. We'll communicate with everyone what that is and what it'll look like in our clinic specifically. Next, we'll educate the team so they can use their knowledge to empower others. Then we'll use our shared vision to lead a team-wide shared celebration of small wins and victories. We'll correct any process flows, and then we'll provide valuable feedback and positive reinforcement to everyone's changes and behaviors. The primary outcome I'm evaluating in my project is the reduction in PHQ-9 scores after 12 months. This aligns with the CoCM model by Chang. A secondary outcome to be measured is treatment adherence, which will be assessed at the end of the 12-month period. It'll specifically be determined by reviewing attendance records with the number of sessions completed to the number of recommended. Another outcome being measured is staff engagement. This will be assessed at 3-month intervals throughout the project to ensure fidelity and gather ideas for future improvements. Staff engagement will be evaluated through self-report questionnaires followed by qualitative interviews about the project. Data will be collected and measured after 12 months using the EHR. An independent t-test will be used for the PHQ-9 scores and treatment adherence outcome. Provider engagement and satisfaction will be measured using ANOVA at 3-month intervals. Qualitative themes will be gathered during interviews, offering valuable insight into how the program is working and any ideas or suggestions staff has for improvement. Additionally, common themes will be identified and analyzed. This helps serve as an indicator of fidelity and engagement to the project. The first part of my dissemination plan will be an informal revealing of findings for the clinic in a roundtable presentation setting. This will include the team that participated as well as any staff members who wish to view the findings. We can utilize tools such as handouts and posters to provide to those who attend and post them around the clinic. Additionally, leveraging technology to our advantage can help disseminate the evidence more effectively. This can include websites, webinars, or even updating the clinic's social media accounts. Next, we can provide organizational level presentations to affiliated clinics. Eventually, we can progress outward into other non-affiliated pediatric primary care clinics utilizing the same tools listed above. Finally, submitting the findings professionally can further enhance this dissemination process. Online journals such as Pediatrics, which is one of the official peer-reviewed journals of the American Academy of Pediatrics, or professional conferences such as Pediatrics Reimagined, a conference focusing on enhancing patient care through integrated medicine, can help. Before we conclude, I'm reminded of a quote from our favorite neighbor, Mr. Rogers. He says, "When we can talk about our feelings, they become less overwhelming, less upsetting, and less scary. The people we trust with that important talk can help us know that we are not alone." This quote underscores the importance of addressing children's mental health needs in a timely and age-appropriate manner. By teaching them at a young age that emotions are normal, valid, and acceptable, we can work towards reducing stigma for future generations. Additionally, using age-appropriate vocabulary, like Mr. Rogers does, helps them understand and express what they are feeling. Equally important, it guides us in teaching children what a safe and trusted person looks like, so they can develop healthier emotional responses and relationships throughout their lives. The CBP project assesses using a collaborative care model to enhance patient outcomes. I provided evidence the CoCM has the potential to reduce disease burden, improve treatment adherence, and increase access to care in the pediatric community, emphasizing its importance and role in primary care. With increasing mental health needs and a shortage of mental health workers, solid evidence-based, cost-efficient solutions are necessary. By integrating the CoCM into pediatric primary clinics, patients receive timely, organized care to support and enhance outcomes and improve quality of life for patients and families while reducing the burden on an overloaded healthcare system. And thank you. These are my references. Thank you.